Thank you all so much. Very interesting discussion earlier, and I wanted to welcome all of the fellows and everybody else involved with setting this up. Big thank you for having us all here and for all of you attending. By way of introduction, I'm Dr. Bankole, currently in sunny Virginia, where we've had temperatures over 100 degrees. So those of you in colder areas and rainy areas, my apologies. And with that being said, and with the lay of the land being explained, I will hand over to my co-moderator, Dr. Sajin, to introduce our lecturer.
Great, thank you so much, Dr. Bankole. Hi everyone, I'm Didam Sagan, rheumatology fellow from University of Chicago. It's my absolute pleasure to introduce Dr. Chet Oddis. Dr. Oddis is professor of medicine in the University of Pittsburgh School of Medicine and director of the UPMC Myositis Center. His academic interests center around the investigation and treatment of inflammatory myopathies, with an emphasis on the clinical features or the antibody associations, pathogenesis, and treatment. Dr. Oddis was the principal investigator on the RIM trial, the rituximab in myositis trial, the first multi-center clinical trial in myositis funded by the NIH, and largest clinical trial ever completed in adult and pediatric myositis. He authored the consensus guidelines for the conduct of clinical trials in myositis, continues to coordinate myositis clinical trials, including the investigation of autoimmune interstitial lung diseases. He directed or co-directed the fellowship training program at the University of Pittsburgh between 2001 and 2019, received the Clinician Scholar Educator Award from the ACR, chaired the ACR Annual Meeting Planning Committee from 2012 to 2014, and was selected as ACR Master in 2019. He also served as an associate editor for the Arthritis and Rheumatology until 2020. With that, Dr. Oddis, please take it away.
Okay, now, can you hear me okay, first of all? Now, I'm sharing my screen, correct?
No, not yet.
Okay, hold on. Now, let me see.
Yep.
Can you see it?
Yes, we can see your screen.
Can you still see it?
Yes. No, no longer.
No longer. Let me have to be patient for those of us who are older and a little slow. I don't want to hear any laughter in the background or I'll cut you all off. Okay, there's my disclosures. Can you see those?
Yes, we can.
All right.
Thank you.
Okay, let's move on then. Okay, so this is, well, first of all, thank you. I see that there's, are there mostly fellows on this call? Is that correct?
Yes, correct.
I recognize a few names. Thank you, Didam, for everything. Didam has been an all-star in the myositis world already, clearly surpassing anything that I'll ever hope to accomplish down the road. So welcome, Didam. You've done a great work in myositis already. So today, I'd like to discuss some features of non-inflammatory myopathies, including some of the myositis mimics. It's kind of tough to do a comprehensive assessment now. We're going to kind of focus on hyperCKemia in a way, but we're going to filter in a lot of other things here as well. And we're also going to discuss some selected features of myositis classification later on. So this is a case-based approach, okay? So you can see this slide that says case 1, correct? And we're going to kind of go through different cases and bring up some points that I believe are important. So this is a case that, type of patient that you will see. This is a 65-year-old guy that, these are all real cases that I've seen through the years, and really most of these cases, I've seen many similar cases through the years. So this guy had a kind of the insidious onset of muscle weakness, had a high CK, had a myopathic EMG. He was told that he had polymyositis when he got a biopsy, and he was actually treated for polymyositis for many years. He got prednisone, he got steroids, he got methotrexate, then he had methotrexate and Imuran, and he didn't get any better. And you know, when I saw him, he was also complaining of falling episodes. So when I saw this guy, obviously some things immediately come to mind, and one of them that comes to mind is inclusion body myositis. And although it's rare, you're going to see it in your fellowship. And what you'll probably also see is you'll see it missed in your fellowship, because it's the most common myopathy actually in middle-aged to elderly people. And you need to think about this entity of inclusion body myositis whenever you're confronted with a patient that has, quote, refractory polymyositis. Unlike some of the other diseases that we see in rheumatology and that you'll see related to the myopathies, it's a male predominant disease. They're more often elderly, late middle age to elderly. And the weakness, we can often tell when a patient has their first symptom of an autoimmune disease. They can remember it. Well, these patients oftentimes, it sneaks up on them. They have painless muscle weakness, slow progression, and unlike classic polymyositis or dermatomyositis, they have distal and asymmetric muscle involvement. And if you see a, quote, polymyositis patient with a foot drop, then you better think about an IBM until you can prove yourself wrong. And they have a characteristic pattern of muscle atrophy in the forearms, flexors, the quadriceps, intrinsic muscles of the hands. And this is taken from, actually, one of them is my patient, the other is taken from the literature. I don't know, can you see my pointer?
Yes.
Okay, so this is a patient taken from, and what do you think this is right here? That's actually the femur. That's a degree of atrophy that you can get. And this is a patient that I saw many years ago with significant atrophy of the forearm, the so-called scooped out sign. So just to give you an idea of the degree of atrophy, this is a normal, just quick cross-section of what your thigh should look like. You got a lot of muscle on top, got a lot of muscle on bottom. Look at this patient with IBM. They've got all this fatty replacement, and this is the femur right here. And you can see that you have a tremendous amount of quadriceps atrophy. So when you start seeing that in patients, in conjunction with the other things that I pointed out, you better start thinking about inclusion body myositis. And there's a distinctive histology. And a lot of times it's called polymyositis because you get these lymphocytes that surround muscle fibers. And sometimes you can see here that this lymphocyte invades. This is a great example of invasion. Well, you think about invasion of a muscle fiber, and most of the literature in the past talked about polymyositis, but this is actually IBM. And the IBM part of it comes out because of these vacuoles. And you can see these vacuoles, these rimmed vacuoles on special staining. So this is IBM. This is what it looks like clinically and what it looks like histologically. And I saw earlier that Ken O'Rourke was on this call. And I remember Ken asked me to give a talk on IBM treatment and IBM in the past, and I put up this blank slide. And Ken wasn't very happy because this is a treatment that we have now for IBM. And it's very unsatisfying because really nothing works for this disease, which is unfortunate. And it's tough to sit across the desk from a patient with IBM and tell them that there is really very little we can do. So let's talk about mimics and hyperCKemia. First of all, the list is, this is essentially an over an hour lecture by itself. But when you talk about polymyositis mimics, one of the things at the top of the list are endocrine myopathies, and that can be hyper or hypothyroidism. And in fact, this comes from an article a long time ago, over almost 20 years ago, that talked about hypothyroid myopathy. And I've highlighted some things here, and I'll come back to this red highlighted stuff later on. But first of all, in hypothyroid myopathy, the CK can be elevated, and it occurs without either hypothyroid or muscle-related symptoms, actually. It can be kind of like asymptomatic hyperCKemia. But then you can also have many diverse symptoms. You can have myalgias, no CK elevation. You can actually have hypertrophy and stiffness. You can have weakness and cramps. Or you can actually have a proximal myopathy that looks very much like polymyositis. The EMG can be normal, but it can be myopathic. And sometimes the biopsy is normal if you ever biopsy these patients. In the past, it was sometimes done. But sometimes you can actually see inflammatory infiltrates. So remember these 4 things that I highlighted here, because that's actually criteria for polymyositis. We'll come back to that later on. Well, one of the big things that you can see with mimics and with elevation of muscle enzymes are drug and toxic myopathies. And high on the list, look, again, this actually is another hour lecture in itself, just to talk about, drug myopathies. Statins are high on the list. And, we all know that statins are incredibly prescribed medications. This is old data. In general, though, let me start off, but statins are generally well tolerated, but they get kind of a bad rap out there for causing a lot of muscle and joint problems. And this is older data. I don't even know when this might have come from 10 years ago. 30 million patients are prescribed statins. That's a big number, okay? And the spectrum of toxicity is broad. You can get life-threatening rhabdomyolysis to just plain old simple myalgias, muscle aches and pains. But it's kind of like the fear that people have out there because of the bad rap I talked about of the serious complications and some patients that have intolerable myalgias that actually leads to, I don't know, probably still fairly accurate, to 5 to 10% of patients saying, I don't want to take that medication, or, they start to develop some arthralgias and myalgias, they stop it. And, we know that these are pretty effective and pretty good medications. So if you look at the myalgias part of it, I actually, as I said earlier, can affect, up to 20% of statin users, looking at some old data that's in the cardiology literature. And if you look at a smaller cross-sectional study of 1,000 patients in the primary care setting, published about 10 years ago, actually about 1.5 time increased risk of muscle complaints in statin users versus non-statin users. So, there's the wrap there that we talked about. And there's been similar results in other studies. You can perhaps predict myopathic events in statin users, and that seems to occur if there are concurrent medications, fibrates, steroids, calcium channel blockers, if they're older, if there is concomitant hypothyroidism or a higher BMI, and certainly if there's hepatic dysfunction, which obviously affects the metabolism and the loss of these drugs in your system. Which brings me to case 2. And again, this is a real case. And I want to emphasize here, this is you can see this is an older patient. I actually just saw a patient a couple of days ago that looks similar to this. So we have a lot of these types of patients. But this was a lady with hypertension, dyslipidemia, obviously, had uterine cancer. She got started on atorvastatin, and the dates here, July 2004. Not until 4 years later did this patient develop what she thought was lower extremity muscle weakness. And then, she talks to her doctor, and he says, yeah, I think you're just getting old, we'll just keep an eye on things. And then several months later, difficulty walking up steps, lifting her arms overhead. Her daughter goes on the internet 10 years ago and said, I think you ought to stop this statin, Mom, and, see what happens. So she stops it on her own, but she doesn't get any better. And she goes back to that doctor in the summer and fall of that year. And he gets a CK and it's 6,473. And he says, I think that's crazy. That's an error. And he repeats it and it's 9,300 a couple weeks later. She's got an ANA. I just put that in there because it ended up being a red herring. She didn't have anything else. And then she gets admitted to the hospital because of the degree of muscle weakness. Her PCP kind of freaked out when he saw these numbers. And she gets a biopsy and it shows myonecrosis, no inflammation, no vasculitis. And this isn't her biopsy, but it could have been. I just pulled this from the literature. You can see that there's fairly normal muscle fibers and then necrosis with, eating up of the fiber, but not a lot of lymphocytes, which is a little bit weird, in patients that have an inflammatory myopathy, because normally there's lymphocytic involvement. So she gets treated with prednisone and her CK and her weakness improve, okay? Now, I'm gonna kind of put this case on hold, and because I hadn't seen her yet, But what came out in 2010, and remember, this is just 10 years ago. This isn't something that we've known for 20, 30, 40 years. There was this article that came out because I was seeing these patients that had pretty significant problems with statins, where their CK would be off the wall. And then this article came out, and it actually came out, as you can see here, in the neurology literature. And patients with what were termed immune-mediated necrotizing myopathy, we'll just call it IMNM, associated with statins. And these patients, just to give a brief summary, they were approximately weak during or after statin use. They had high CKs, and they had persistent weakness and elevated CK even after stopping the statin, which made a lot of these doctors think, oh, it's not the statin, something else is going on. But what happened is that these patients got better with immune suppressive therapy. And their muscle biopsy showed necrotizing myopathy without significant inflammation. And I'll put up the slide that came from that article. And you can see here that it looks a little like what I showed you already. Necrosis, necrosis, but actually other fibers without a lot of lymphocytic inflammation. And this was not just 1 or 2 patients. This was 25 patients from 2 centers, 24 of whom required immunosuppressive therapy, and 15 of whom relapsed after that therapy was stopped or tapered. Again, necrosis, no inflammation. So this caught our eye. And about the same time, another article caught our eye from Hopkins. And that was the identification of an antibody in patients with a necrotizing myopathy. And I'm just going to kind of go through this quickly, but this is what's called a precipitation gel. And what they found, what the investigators found, was that there was an antibody, and it was an antibody against a doublet, 100 kilodalton and 200 doublet. And in 38 patients with necrotizing myopathy, they had this abnormal antibody. And look at the similarity between the neurology presentation. All were weak with a high CK. 2/3 or so had statin exposure prior to weakness. Most over the age of 50, all responded to immunosuppressive therapy, and many of them relapsed. So at the same time, we get this different independent report from a different institution. So to kind of cut to the chase and to get to the crux of the matter, the question is, what's the antigen? You've got an autoantibody against this doublet here. So what is this antigen in this necrotizing myopathy that's associated with statins? And believe me, this is a lot of work. A lot of this very elegant work came from Andy Mammon, who is actually a neurologist, previously worked at Hopkins, still works there part of the time, but he's now switched over to the NIH. And what Andy identified, and again, really cutting to the chase and very elegant work, was he knew, and we all know, everybody on this call knows, that statins lower cholesterol by being inhibiting HMGCR, okay? Short name for the hydroxymethylglutarate reductase. Interestingly, HMGCR expression is upregulated by statins. So what Dr. Mammon said was, okay, I'm going to see if this autoantigenic target could possibly be HMGCR. So he chose that as what's called the candidate antigen for that 100 kilodalton band, since HMGCR has a very similar molecular weight. And what did he find? Well, again, a year later, he found that HMGCR was indeed that 100 kilodalton autoantigen target. He developed an ELISA for that particular antibody, and all 16 doublet positive patients ended up being anti-HMGCR positive. And when they looked at their myositis cohort at Hopkins, they found that 6% of their cohort were indeed HMGCR positive. So that gives you a good idea where, clinical presentation can actually predate and fuel a real elegant, elucidation of an autoimmune mechanism. So back to my patient. I saw her in 2002, right around the time that and I keep this case because it was right around the time that all of this stuff was coming out. She had a CK of 5800 when I saw her, and she was pretty weak, as you can see here. Her deltoids, her neck flexors, she couldn't get up from a chair very well. And I added IVIG after failing methotrexate and Imuran, and basically her strength normalized in 3 months. In an almost 70-year-old woman, her strength normalized. And her CK improved, but it never really normalized through the years. And she struggled through the years with intermittent flares. And indeed, whenever this test for that ELISA became available, this lady was anti-HMGCR antibody positive. And through the years, Dr. Mammon and others have actually now, there was a brief article in the New England Journal 5 years ago or so, 5-6 years ago, that actually suggested IVIG as first-line therapy for this statin-associated autoimmune necrotizing myopathy. So I put this in here as a very good example of how you can look at the CK and it can actually look very elevated in many instances. And I put this up here again. This is not an evidence-based approach. This is given to those of you, and we all see it, where we kind of have in our mind a statin myopathy strategy. So it's not a bad idea for practitioners to get a baseline CK before starting a statin, because you'll see this stuff that we just talked about, right? And then we'll stop the statin if you see it. And many times the symptoms will normalize. If they do, when you stop the statin, you can stop there. You don't have to work up. You can try another statin. You can lower the drug, whatever it is. But in some of those patients, they'll have persistent symptoms and or a CK elevation, in which case, as I said earlier, rule out the routine causes, polypharmacy, hypothyroidism, other drugs. But sometimes that CK is off the wall. And when that CK is off the wall, then you have to consider this IMNM, in which case it would be wise to order an anti-HMGCR antibody. And I put this up where you said, well, you know, everybody knows about this, but I actually saw a patient just on Tuesday. And the rheumatologist, after seeing this patient for 3 years, had not yet ordered this and was not treating this patient with anything other than steroids. So just keep in mind that there is a strategy that we can follow. I put up another antibody called anti-signal recognition particle. And that, I put this up because this is another antibody where you can be quite weak, have a high CK, show that necrotizing myopathy that I talked about, and really not have many other autoimmune manifestations such as a DM rash or interstitial lung disease. And these patients also have a poor response to therapy. And they similarly have that refractory, persistently high CK. And in fact, I've almost called them looking like muscular dystrophy. And indeed, these patients have that same necrotizing myopathy without inflammation. Here it is right here, necrosis, very little inflammation, as you can see in this article that actually presented in the neurology literature many years ago. So let's move on then to other, as I said before, drug or toxic myopathies are a lecture by themselves, but I thought I'd include a couple things in this because, you know, I think that, you know, as rheumatologists, we give patients colchicine, as you just heard in the first lecture, and it's unusual, but colchicine can cause a neuromyopathy. These patients can get proximally weak. They can have an elevated CK. They can have a myopathic EMG with myotonia. The predisposing factor can be CKD. They get this microtubular effect, and they have a characteristic pathology with a vacuolar change and actually very minimal inflammation. So in your patients that have been on colchicine for a while, you know, I just want you to keep in mind the possibility of colchicine myopathy. Similarly, another medication that we use a lot is hydroxychloroquine. And antimalarial myopathy has been reported in the literature, and it's been a little bit more commonly reported than previously recognized. But if you get persistent CK elevation, and look, you're going to see this in our patients, you're going to say, well, maybe they just have myositis. Well, maybe it's not myositis. Maybe they have antimalarial myopathy in the lupus patient, and you should do an EMG and a biopsy. And it's interesting that there are some biopsy changes that are rather classic. We don't oftentimes get electron microscopy, and you may just see some changes of vacuolated fibers and some necrosis. But if you actually get electron microscopy, you can get these kind of weird looking curvilinear inclusions and lipid inclusions in patients with hydroxychloroquine myopathy. And unfortunately, sometimes you can even have cardiomyopathy associated with Plaquenil and antimalarials. And this has been reported. We actually reported we're one of these articles there. So just keep it in mind because that's a medication we use a lot of in lupus and even rheumatoid arthritis. Metabolic myopathies, not touching it today, sorry, another lecture by itself, but I thought I would briefly mention mitochondrial myopathy because I put in this slide, you know, there's the differential is huge again for patients with elevated CK, but just some clues that you might want to consider in a patient that might have a mitochondrial myopathy. There might be a family history of myopathy, other neurological findings, exercise-induced exacerbation, rhabdomyolysis, and some characteristic biopsy features where you get these ragged red fibers. So if you see ragged red fibers, think mitochondrial myopathy. They have the potential for multi-organ disease, and sometimes the CK is not that elevated. So again, just something to consider. And muscular dystrophy, as you well know, isn't confined to childhood. You know, there are some adult onset muscular dystrophies. Limb-girdle muscular dystrophy is one disorder, and in adults, it can be mild. The course can be indolent. Of course, in kids, oftentimes they have a pretty significant disability. But it's just something to keep your eyes and ears open for. And it's interesting. This is a myopathy called dysferlinopathy. You said, well, this is very unusual, and it is. It's called Miosi myopathy. But wouldn't you know that we just, in a patient that I've seen for a few years, that I knew didn't have classic autoimmune myopathy, eventually she agreed to a second biopsy, and just this week, this particular myopathy was diagnosed in a patient that's received a fair amount of immunosuppression. So they can get a prominent inflammatory response. They may or may not have the classic dystrophy. Early stage, like I said, easily mistaken for an inflammatory myopathy, but look at what they get. They get a CK elevation, they get myalgias, they get weakness, and it very much looks like polymyositis, like it was with this lady who was referred to me. And they can get an inflammatory infiltrate in the endomysium. This is a patient that has scattered fibrosis, but also has inflammation. But the diagnosis is made whenever you look at the biopsy material and you can actually get a dysferlin stain. It's kind of a misnomer. Dysferlin is actually what you should see, even though it says dys. But this is what a normal biopsy would look like, okay, where you get dysferlin, and this patient has no dysferlin in their membrane. So this is a patient with a dysferlinopathy. So let's move on to talk a little bit more with more common things, and that is what you will definitely see in your practice and what primary care providers see in their practice. So this is again, I've probably seen 100 of these. It's a 52-year-old African-American guy who got referred to my office for a CK. As you can see, he had dyslipidemia, he had hypertension, but really nothing else. He was taking a thiazide, completely negative review assessment. And he said, you know, I'm only here because my doctor sent me, she said you like to see patients with these muscle enzymes. And I'm doing a muscle exam, and this guy's as, you know, strong as an ox. I mean, you can hang off this guy's arms. 5/5, no problems. And I'm talking to him, and this was, again, a few years ago, and it was presented to me by a fellow. And I went into the room, and I said, you know, anybody ever tell you that your liver tests were elevated? And he goes, well, it's kind of interesting you asked that. He goes, I went into the Army in my 20s, and they said my liver tests were up, and they wanted to do a liver biopsy, and I told them no way, and because I didn't drink, I lived a pretty clean life, and got just a routine workup, no problem with his liver. So the problem there was that this guy likely had this elevated CK for a long time, and his liver tests were up because the AST and the ALT were up because they're liver enzymes, but they're also muscle enzymes. So just let's talk a little bit about the CK, because this is a problem that you will definitely see. So what do we know about the CK? You know, first of all, what's an abnormal CK? Well, it's variable. And when you look at the reference range of a normal CK, you'll see that there's a central 95% curve, you know, in Caucasians. And most of the data that comes from the normals comes from Caucasians. So you assume a Gaussian distribution or a bell-shaped curve for the CK, right? And if you do that, the normal CK, you know, usually it's 200. Sometimes it's 190 or 240 or whatever it is. But if you use those parameters of the bell-shaped curve, you're going to have 10 to 20% of males and even a smaller percent of females who will have hyperCKemia. hyperCKemia. So it isn't a bell-shaped curve. And the distribution of CK in healthy males and females actually is this type of skewed curve, which is not bell-shaped, which means that the 95% cutoff really can't be used to define the normal CK, because you got these people out here that have elevated CKs, all right? So the CK in the healthy population is markedly skewed toward higher values, and it is non-Gaussian, okay? So, kind of a busy slide. I just want you to look here at the orange bar, okay? Look at this. This is basically the CK showing you how it varies by gender and ethnicity. This is the kind of like the CK in the African-American male. Look at the level here, okay? Then look at the level in black females. Then look at the level in white males. And look at the level in white females. So basically, CK levels vary: black male greater than black female, white male greater than white female. That's important to understand. That explains a lot of the variability that we see. Further, you can actually see increases in CK for lots of different reasons. And this was published about 10 years ago, looking at hyperCKemia in a pretty good cohort of patients, where there was a transient rise after exercise up to 10 to 30 times normal in strenuous exercise. It slowly declines over 7 days. And the degree of elevation depends on the type and the duration of the exercise. So the initial step in assessing hyperCKemia, repeat it, okay? In these patients, if you avoid exercise for a week or so and you repeat it, 70% of patients will normalize their CK with this simple step, as noted, giving you some evidence-based data in this particular article. Further, which kind of goes back to the case that I presented, a lot of these patients with idiopathic hyperCKemia have a benign prognosis. And this is another short study, a small study done many years ago, where 55 patients were followed for, nice follow-up, 7.5 years. And the CK normalized in 12 or decreased in most of those patients. And indeed, most of these patients remain asymptomatic or with minimal symptoms through the time period that you can see. And in fact, 78% still have persistent hyperCKemia, but it's lower. And they have not developed significant myopathic problems. So, elevated muscle enzymes in the absence of muscle disease. I've kind of shown you the demographic things that you need to keep in mind. I've also told you that they'll have exercise and manual labor contributing to this, but there is a subset of patients who may just have idiopathic hyperCKemia. I don't know how, is there a way, can I just ask this question, and I don't know, how are we doing this? If anybody wants to.
Dr. Oddis, you can read the question and I'll pull up the polling.
Okay. So this is a 30-year-old guy, African-American guy with an elevated CK of 750. You can see the normal. Past medical history, he's got a similar CK elevation of 1 year ago. His PCP now wants him to start on a statin for dyslipidemia, and he consults you. Physical examination normal, proximal and distal muscle strength, and he has no musculoskeletal symptoms. What would you do? Refer the patient for an EMG to a neurologist, start the statin and follow the serum CK, send the patient to a general surgeon for a muscle biopsy, or administer a low dose of steroids for a period of time and then recheck the serum CK in 1 month. And if it's okay, then tell the PCP it's okay to give the statin. How long do I wait? Everybody got the right answer. So that's good. You're paying attention. So given a similar history of CK elevation, I kind of put in 2 factors here, on 2 of the cases, threw in the question that we many times get, and that is, can I give this patient a statin? And given a similar history of CK elevation previously, the lack of any muscle weakness, and the fact that he's African-American, the likelihood of any myopathy is quite low. And it's inappropriate to do an EMG or a muscle biopsy. And certainly steroids are not indicated, even at a low dose. try to trick you with a low dose. Not even with a low dose. You start the statin and you follow the CK. Why? Because you know where he started in terms of his CK. So again, often no need to extensively evaluate the patient with an EMG and a muscle biopsy with idiopathic hyperCKemia, especially when you know that it's been stable over time. I'm not going to go through, this is kind of a long, I actually borrowed this and adapted it from one of my colleagues at the NIH, Fred Miller, who's had a longstanding interest in myositis. Just some helpful clues if you're looking at myositis mimics. If you're going to look at an evidence favoring an autoimmune process, they may have a family history of autoimmunity. It doesn't have to be myositis, and it often isn't. Hashimoto's, lupus, MS, in other family members. If they have muscle atrophy after chronic symptoms, if you flip over to the evidence against immune-mediated, perhaps it's a dystrophy, they'll likely have a family history, but of a similar muscle weakness pattern. They may be asymmetric. They may be distal. There may be atrophy. Here, there would be no neuropathy. Here, if you see neuropathy or fasciculations, you better think of something else. Here, the CK is oftentimes minimally elevated or not, or very elevated. And over here, it can be the same type of thing. But on the immune-mediated side, if they've got fever, arthritis, other CTD symptoms, then you start looking towards the immunologic variety of myositis. And if they've responded to prior therapy, that's autoimmune. But there's usually a lack of other systemic features, no response to therapy. And again, serological abnormalities, which is another very interesting talk. Rhabdomyolysis is rare, whereas you may see rhabdomyolysis in the patient with a non-immune myopathy. So let's just finish off, hopefully I have about 10 minutes or so, looking at a few other things related to myositis. And this is our classification of myositis. You'll see this through your training. This is what I talked about earlier, the old diagnostic criteria for myositis. Remember, we were talking about the hypothyroid patient that's symmetrically weak, elevated enzymes, myopathic EMG, characteristic biopsy, and then, of course, there are cutaneous features. Well, there are problems with this old criteria, and that is that there's no good way to exclude other myopathies. There's a misclassification, and that's why I put in the IBM case. There's no consideration of what we now know to be amyopathic dermatomyositis. And, the criteria are kind of vague. So I don't want to go through it, but there's now a new criteria that was kind of published just within the last couple of years. And it came from a lot of effort, a lot of multidisciplinary approach. These new criteria are actually derived, and each item has a weighted score. Again, this is very complicated. The purpose of this lecture is not to go through this, but just to kind of inform you that there's this new criteria out there, and there's actually a web calculator that you can use to diagnose it, and it's weighted. It gives different weights to the different manifestations that patients may have. And I'm actually going to just skip through this because I want to go to patients that have dermatomyositis, and I put all of these things up. It's amazing that the number of different rashes that you can have with dermatomyositis. But in a way, whenever the patient is in the office with you and they have Gotrin's sign or Gotrin's papules and an extensor rash or even a facial rash, sometimes even necrosis. This is a guy holding his hand next to this is the Holster sign. This is a heliotrope, a V-neck rash, the Shull sign. The diagnosis isn't hard here. This is dermatomyositis as opposed to the patient with polymyositis. So this ends up being an easy diagnosis. It may not be easy to treat, but this is a patient with dermatomyositis. And sometimes the skin disease can be the most dominant feature in these patients. And I put this up. I showed some of these before. This is a patient, a guy with very refractory dermatomyositis. And this is a patient with, these are patients with very refractory DM with scalp rash. This lady was almost suicidal because of this. This lady couldn't even wear glasses because it irritated her skin so much. So the rash of dermatomyositis is prominent. It's not the topic of this talk, but I'm going to come back to dermatomyositis when it comes to the CK in a minute, because I want to emphasize one other thing, and that is going back to polymyositis. And the reason that I emphasize it is that these patients don't have a rash, right? They come to you and they may be weak, but as we just learned, there's a lot of reasons why patients may be weak. And we've gone through some of these, but you always have to keep these in mind in the patient that presents to you with an elevated CK, and maybe the doctor referring says, well, I've got polymyositis. But remember, they may not have polymyositis, which brings me to the point that muscle biopsy is a must in polymyositis. Whereas the patient with classic dermatomyositis, you may not have to do a biopsy because they have the classic rash and they're weak, and you can move on to treatment. We still oftentimes will do an EMG and a biopsy because we have a nice strong collaboration with a neuromuscular pathologist, but you may not have that luxury. But the reason that you have to do the biopsy in polymyositis is to verify the diagnosis. And PM looks different from dermatomyositis. They are both autoimmune, okay? As I said before, you may see this lymphocytic invasion of a non-necrotic fiber with polymyositis, but the histology of dermatomyositis is a bit different. You can have perifascicular atrophy. You can have more B cells. You can have what's called membrane attack complex or complement deposition. So it looks different. So, but this is why you have to do it. And which brings me to the last case, and that is a patient that was referred to me for, quote, amyopathic dermatomyositis. This was a 44-year-old lady who had the mild Gaucher sign over her knuckles, and she had periungual changes, and she had completely normal muscle enzymes. The LDH, slightly elevated, CK was 83, AST, ALT, LDLH normal. And she said, well, I'm coming to you from the dermatologist because, you have an interest in this disease, but I'm not weak. But when I examined her with our fellow, she actually did have subtle iliopsoas weakness, in her hip flexors, which were 4+/5. And I sent her to the neuromuscular fellow that I told you about, the guy that I collaborate with, and he said, she's got borderline changes, but I think I'm going to biopsy her. And the biopsy that I showed you in the earlier slide, this was her biopsy. This is not normal, okay? This is a pretty intense lymphocytic inflammation in a patient that had subjectively told me that she's not weak, she feels fine, and actually had completely normal muscle enzymes except for a slight elevation of the LDH. So the point here, and this final teaching point that I really want to make as the last slide, is that physical examination is still important. This patient had no subjective symptoms, a normal CK, essentially normal EMG. So normal CK active myositis occurs, and you need to remember that it is particularly in patients with dermatomyositis, both adult and childhood. All the other enzymes may also be normal. So the muscle biopsy is still helpful, even in dermatomyositis. So it's kind of a whirlwind tour, mixed a little bit of myositis in with looking at muscle enzymes. Again, we have a pretty strong collaboration here and a strong myositis center. I'd also just want to mention that a lot, we've written a book over the past year, Doctors Agarwal and I, and it can really provide you some nice management. We've actually incorporated a lot of experts around the world into giving us a good overview of many manifestations of myositis.
Thank you so much, Dr. Oddis. I cannot believe that someone is able to go through the bulk of myositis, covering everything and teaching us all within that limited time span. That's a really wonderful job. Thank you so much, and I'm sure the fellows agree. We're going to open the question and answer session, but I'm going to be self-indulgent for a second and just ask in today's world, where we all wonder about equity and equality, would there be a concern about the normalization of CPK for race and the potential under treatment or under investigation of elevated CPKs in people of color?
Absolutely. Yeah, I expected to hear that question, and thank you for asking that question. You know, it almost begs the question of having a different normal demographic, a demographically driven, you know, variation in what's normal. You know what I mean? So I don't think that totally answers your question, but I'm acknowledging it, and I put that out there because we have to think about that, and we have to think that, you know, you say, oh well, maybe, you know, that CK, you know, that's, you know, we don't have to worry about it. The patient's strong, but it goes both ways. We don't want to over diagnose a patient that has demographically driven differences in laboratory tests. We don't want to overdo an EMG and a muscle biopsy, you know, at the same time that I'm saying that we don't want to underdiagnose it as well. You see what I mean? So I think you bring up a very good point. I don't know if I have a remedy, but I acknowledge that.
Thank you so much. And with that, I'll hand over to Dr. Sagan. Thank you.
Sure. So I'll start with the first question that was posted in the chat. So would you start IVIG for statin-induced myopathy, even without bulbar symptoms?
Yeah, that's I'm sorry, what's the end of it, item? Even without symptoms?
Even without bulbar symptoms like dysphagia.
Oh yeah, okay. So the question here is very simple. You know, you got a patient with IVIG has now been approved by the FDA as the first medication for dermatomyositis. I do not, and you're talking about for statin associated, Denim? Yeah. So, you know, there's a lot of neurologists, and actually the neurologist that I talked about earlier wanted to do a study where they proposed going to IVIG first. In my opinion, in the statin associated myopathy, where there is significant weakness, and they don't have to have oropharyngeal weakness. I really push to go to IVIG early. I do, because most of the time, what do we know about these patients? They've been on statins, are probably older, right? Than the dermato patient, maybe the younger patients that we see. So there's a reason to get IVIG into them early. Number one, it really works for statin associated. They don't have to have dysphagia. My opinion is get it early. And sometimes you can get away with an immunosuppressive. I would not go to steroids alone in these patients. I'd probably, if you want to get a first step and you can't get IVIG approved, give them statin and methotrexate, and then provide the literature to the payers on what we see with the response.
The second question is actually a patient question. So the questioner says that I have a patient who post-COVID had a transient mild elevation in CPKs with mild muscle spasms but no weakness that lasted for about 6 months. And the question was, have you seen something similar yourself? Yeah,
good question again. There's some literature coming out. I don't want to. Actually, this one has been published. It's very interesting that there's been some weird muscle-related manifestations, and one thing that I did see is paraspinal weakness in patients post-COVID, and that actually was reported. I got an email the other day, and I said from a patient, from a doctor in Chicago, and he said, "Have you ever seen anything in the back muscles?" And I said, "I don't think so." I went to this article, and wouldn't you know that there's this paraspinal myopathy that's seen post-COVID. But there are a lot of non-specific things that I've seen post-COVID, cramps, and I got another call of an overt autoimmune myopathy that actually was antibody positive post-COVID. I don't know if it really occurred prior to COVID, to be honest with you, or if it was brewing, but I think we better keep our eyes and ears open for COVID. Why? Because I think the concept of molecular mimicry is occurring with COVID and with a vaccine, potentially.
Another question. So what is the yield of percutaneous needle biopsy compared to open muscle biopsy? You know, whenever I mention this here, always pathologist is concerned that the amount of biopsy, the amount of tissue that we get with percutaneous may not be enough. So what is your experience been with the percutaneous biopsy?
Yeah, we published that item. We published it with Dave. You know Dr. Lacomas, obviously. He's the neuromuscular pathologist that I've mentioned a couple times during this talk. We've actually published that. So a lot of neurologists don't like it. I got to be honest with you. David is a neurologist. I didn't do the needle muscle biopsies, and our data has looked very good. And as you know, it's all about who's doing it. All right. He's a experienced, well-known, well-published neuromuscular pathologist who's also a clinician. He does the EMG, and then he does the biopsy, the needle muscle biopsy at the same time in the same muscle. Why? Because it doesn't allow the artifactual increase that can occur with the EMG needle. He does it right away. So it's all about who's doing the needle muscle biopsy. Our data is very good. And in fact, we get very high yield whenever it's done properly. But that being said, I recognize that in a lot of locations, they're going to do the EMG on one side, and then they're going to do the biopsy on the other side because it is predominantly a symmetric disease, and the contralateral muscle should be involved. So I'm not really hedging on the question because I'm telling you that done in the right hands and under the right circumstance, and look, it saves an operative procedure. I mean, the patient goes to the EMG lab at the University of Pittsburgh, gets the EMG done, gets the biopsy done percutaneously, and we have an answer 2 days later without getting a surgeon involved.
The next question is, in patients with myositis, how often do you see respiratory muscle weakness in the presence of normal skeletal muscle strength? And is it more common in a particular type of myositis?
Yeah, that's a very good question. And I don't think there's a lot of data. So the question is, okay, a patient's short of breath. And I mean, I want to add a qualifier, make sure that, you obviously have to rule out interstitial lung disease, which is much more common than respiratory muscle involvement. And it basically kills my patients with myositis, okay? That's another whole topic by itself. Autoimmune ILD is a killer in myositis because of the associated antisynthetase syndrome and a lot of the other things. But what you're asking is, well, the patient's weak and they don't really have evidence of, or they may not have evidence of peripheral weakness. Can they have respiratory involvement? And the problem with that is that you have to be able to diagnose it, all right? And a lot of people, and that's very difficult to diagnose. Now, if you get PFTs and they're really abnormal and they can't ventilate properly, you can actually do a diaphragmatic EMG in some instances, and that might help you. But, I think it's very uncommon. I think that if you're going to make a diagnosis of respiratory muscle weakness, do your best in consultation with a neuromuscular pathologist to really document that it's neuromuscular, ruling out obviously ILD, and making sure that there's not another unusual problem such as a muscular dystrophy that could be contributing to that. I didn't answer that, in a great way, but that's probably about the best that I can do it. There's just very little data on that.
Okay, and I feel like this question comes up every year. So the question is about cancer screening in myositis patients. How frequently do you screen, and how long do you continue to screen these patients? Yeah,
Adam, you probably know about what's going on through the international group. Rohit Agrawal and actually it's Alex Android, right? Who's leading. There was actually a recently published article, and I can share that with I can send that to you, Adam, if you want to send it out, on some guidelines on screening. Let me just tell you that there is an initiative to provide more solid guidelines, but those are very good questions. So what I would say right off the bat is that dermato is really the culprit more than polymyositis. So if you have a middle-aged, certainly to elderly dermatomyositis patient, male or female, they really should undergo screening, CT scanning of the chest, abdomen, pelvis, tumor markers, along with following any other particular abnormality. For example, if they're anemic, you gotta look at the anemia. Age determinant screening, certainly. All the screening that we know comes with age, but chest, abdomen, pelvic, CT, done at the time of diagnosis. And then the next question you asked is, how often do you do it afterwards. Tough question. I can only tell you that I don't think you have to do it yearly. A lot of people have recommended that. I think you have to do it driven by any change in the clinical features. For example, let's say the patient doesn't respond at all to dermatomyositis, and they are persistently weak, and initially their screening is negative. Well, in that patient who has refractory DM, and perhaps they start to develop other unusual manifestations, more severe necrosis of their fingers and things like that, then I would consider rescreening in that patient. But I don't think we have the data now to say, do it 1 year, do it 2 years post a diagnosis, particularly if they respond well. I don't think you have to do that. The other thing that I should mention, as you well know, there's an autoantibody called anti-TIF1 gamma. And in the patient who has anti-TIF1 gamma, that's one of the autoantibodies associated with dermatomyositis, there is a higher frequency of malignancy. So that's another kind of red flag that you have to keep in mind. It is commercially available, but I can tell you as well that that's the most common autoantibody in my dermatomyositis patients, and most of those patients do not have cancer.
There's also a question about treatment or the use of steroid-sparing agents. So in inflammatory muscle diseases, what would be your steroid-sparing agent of choice, either in HMG-CoA positive patients, SRP positive patients versus seronegative patients?
Okay, good. Well, we only talked a little bit about the antibodies. As you well know, there's a ton of antibodies associated. Let's talk about HMG-CR. I would say what I said earlier, and that is I would go to IVIG in that bad necrotizing myopathy with HMG-CR antibody positivity. But in the routine patient with, with overlap myositis or dermatomyositis, I start methotrexate in association with steroids in these patients. And it's the rare patient that I just give steroids to, unless perhaps maybe it's an MCTD patient that has mild myositis, maybe just steroids. But for the most part, if I've diagnosed myositis, I'm given a methotrexate right off the bat, along with a steroid-sparing agent. After that, there are many other agents that we have available. I oftentimes will add Imuran to methotrexate. We can go to IVIG. We can go to Cellcept. We can go to tacrolimus. But you have to be careful in the patient with interstitial lung disease. If it's active and significant, then you don't want to give them methotrexate, do you? You probably want to give them Cellcept, perhaps even IVIG, or perhaps some of the other medications such as rituximab or even tacrolimus. Treatment is much too difficult to address with that simple question. But yes, I go to a steroid sparing early. I like methotrexate. I think it works well for myositis.
Okay, I think with that, I would like to thank Dr. Oddis for this fantastic lecture and the Q&A session.